As Irina mentioned, that moms suffering from postpartum depression can also be suffering from a substance use disorder, which we would call co-occurring disorder. And there's tons of statistics out there, and as Jean referred, the amount of the population is expanding in the use of opioid and heroin use. So the statistics can vary, but as of January in 2017, an annual average of 21,000 pregnant women used an opioid in the past month. 22% used heroin, but 28% used non-heroin opioids. So you can see that it's an even higher use than a heroin back in 2017. Oh, would help if I did. In New Jersey statistics, if you need any statistics or every information you want about addiction, there's a website, the Substance Abuse and Mental Health Services Administration, SAMHSA. You can find everything that you need. And in their statistics, it showed in 2015, there were 13,000 New Jersey residents enrolled in methadone opioid treatment versus over 11,000 in 2011. So it shows an increase back then. In a single day in 2015, there were over 1,100 individuals receiving buprenorphine for substance use treatments versus 663 in 2011. Again, it's increasing rapidly. And I just wanted to try and focus on like what you might see in entering the homes of your clients. First of all, if they have a history of alcohol and drug abuse, that might be an alert there because it is a chronic relapsing disease, and every day they are fighting their addiction. They could have an altered mental state. If they're using opiates, they would be nodding off, or if they're using cocaine or crack, they're more excitable and anxious. Cocaine can also cause a sudden hypertension in a young person, and physical evidence. I mean, if they have white powder around their nose or track marks from IV use, and drug-seeking behavior. They may even ask you if you could recommend a doctor because their doctor's on vacation or their doctor's not available. Actually, every doctor leaves a covering physician, so that's not an excuse. I mean, you know, just have them call their regular doctor, and but they could be looking for more prescriptions. For pregnant women, usually if they have late prenatal care, no prenatal care, or it's sporadic, they could have preterm delivery, premature ruptured membranes. All of that could happen medically, but if it's a non-medical reason, they might look into the possibility of substance use. And loss of child custody, we know that DCP&P doesn't readily take away the child from the mom. So it needs to be investigated. It might be something more serious. Why did that mom lose custody of her child? Pain management, as Irina had mentioned about after delivery, the pain management, that needs to be discussed with the provider. Advise your client to talk to their provider, whether it's an obstetrician, a midwife, prior to labor, because once labor starts and delivery, everything is just fast moving. So they need to have this in a calm setting to discuss their options. And they could find non-opioid solutions after delivery. And encouraging the mom to attend childbirth classes because they will learn what different options there are in dealing with the pain. And after delivery, even a mom who may have a history of addiction, they do need pain medication, but it needs to be limited, maybe a few days. The obstetrician I worked with would prescribe Percocet for like 3 days, but that's it, no more refills. But there's other non-opioid solutions as well. However, the thing that moms should be aware of is that they cannot be given any opioid antagonists, especially if they're on methadone or buprenorphine. A very common pain medication during delivery is Nubain. If a mom is given Nubain, and this happened years ago in one of the hospitals, mom was given Nubain, she was on methadone, excuse me, and as soon as she was given that medication, she went into immediate withdrawal, as did the baby. So we wanted to avoid that. So again, advise her to find out what medications are contraindicated if she is on Subutex or methadone. Some of the behavioral signs, as I mentioned about doctor shopping, they may have excuses like why they need to see another doctor, but there is a pharmacy database now, and if the doctors are enrolled in that, it will signal if there's been an opioid prescription for that patient. Dramatic mood swings, again, whether they're agitated or just nodding off. Extra pill bottles in the trash, you might see. The social withdrawal and isolation, they may not want to even talk to you. They may not be taking care of the baby. And sudden financial problems because they are now trying to find their pills on the street, which of course is extremely expensive. So I just wanted to point out the similarities that exist between postpartum depression and substance abuse. First of all, for the mom suffering from postpartum depression, the shame and the guilt. She doesn't want to speak up that she's not happy about having this baby. Everyone thinks it's such a wonderful thing, and she feels guilty that she doesn't feel that way. And also there's the stigma of mental health. They're afraid to speak up because they don't want to be classified as that they think they're crazy. Same with substance abuse. These moms do suffer from shame and guilt that they have this addiction and they can't control themselves because of the brain disease. And again, the stigma. Society will look down on moms more so than men, like Jean referred to, a male using drugs in the home. If the female's using drugs in the home, the children be taken away, but not if the male is. So there is stigma connected with women and childbirth. Medical complications, especially with postpartum depression, they're not seeking the postpartum care that they need. They become very isolated. The substance abuse can have a whole range of complications, placental abruption, or where the baby's not growing well in the womb, the intrauterine growth restriction. They could also have the appetite changes. They're either overeating because they're looking for comfort foods, or they're not eating enough. The feeling worthless, I think that's one of the classic signs of postpartum depression. They do not feel like they're a good enough mom. No matter what they do, they always feel that they're not a good mother. And of course, that they feel the same way if they are using drugs, the feeling worthless. It affects the child development. If you ever get the chance, there's only a couple-minute film called The Still Face. It shows the reaction to a toddler when the mom is ignoring the baby, has a still face and is not interacting with that child. You see the reaction of the baby. So it does have a definite impact on the development of the child. Treatment issues, for the mom with the postpartum depression, there's the antidepressants, there's group therapy, there's individual therapy. And we strongly advise our moms on the phone when we're talking to them to attend the support groups. It gets them out of the house, it gets them connected with other moms who might be going through similar circumstances. We have support groups throughout the state. Each consortia has their support groups, so you could contact any of us for that information. But very important, socialization. Okay, I'm sorry, we're rushing for time, but cultural competence, the speakers this afternoon will really go into it in more detail, but just to give you a quick overview, the definition is the ability to interact effectively with people from different cultures and backgrounds, but it goes beyond race and ethnicity. It includes age, gender, disability, religion. And to be culturally competent is not just being respectful for one's culture, but to be responsive to that client's needs, health beliefs, and practices. And it can also include drug culture, because these moms who may have just been on prescribed medication are now part of the drug culture that is seeking their pills on the street. A totally different culture that forms their own bond culture. And that's kind of a responsibility that we can take on, is to try and break that drug culture of bonding and understanding and replace it with a social, a healthy solution and a healthy culture. And the treatment, as I mentioned, about the antidepressants and therapy. Treatment for substance use, if they're not pregnant, definitely a detox, but as Jean mentioned too, it's a long-term treatment to get the brain back functioning in a healthy way, which is behavioral change that needs longer time. And what happens with this co-occurring, years ago, people, counselors in the treatment, substance use treatment, would say that they can't work with this client until their medical complications are taken care of. The people in the medical end would always say, well, we can't do anything until their substance use is taken care of. So then there has been a diagnosis of co-occurring, meaning you can have both the mental health illness as well as mental health disorder as well as substance use. And the important thing is they must be treated simultaneously at the same time. Okay, and now I will turn you back to Irina, who will discuss the screening and identification and referral. Thank you. Any questions?